Today we're going to discuss the physical assessment of the musculoskeletal system. We will be starting with the structure and the function. First, we'll start with the bones, moving on to the joints, and then talk about what a bursa is. And so the skeleton itself, it's a bony framework consisting of 206 bones that make up our body. The bone and cartilage are very specialized forms of connective tissue, the bone being very hard, very rigid, very dense. The joints are articulations where two or more bones create a union and make up a functional unit to allow mobility. However, some joints do not allow mobility, such as a non-synovial joint, because of the fibrous tissues or cartilage in this area is immovable. An example of a non-synovial joint would be the sutures in your skull. A synovial joint, like your knee or your ankle or your wrist, are freely movable because bones are separated from one another and they're in this joint capsule or cavity that is lubricated by synovial fluid within the synovial membrane. In joints with cartilage, the joints are separated by fibrocartilaginous discs, and they're only slightly movable. And if you think about the largest cartilage type joint would be the vertebrae. Ligaments are fibrous bands. They run directly from one bone to another, and they strengthen that joint, keeping those bones together, and they help to prevent movements that are in undesirable directions. And lastly, a bursa is a fluid-filled sac-like cavity, and it's especially in an area where you want to counter the friction of a joint. And bursas help muscles and tendons glide smoothly together and over the bone itself. They're located in areas of high potential friction. For example, in your shoulder, there's the subacromial bursa. In the knee, the prepatellar bursa as well. As we look at the schematic, this is an example of a synovial joint. Again, they're freely movable. And you can see that the cavity is lined with synovial membrane, secreting the fluid, just like grease on gears. It's helping things to move freely. And synovial joints, there's a layer of resilient cartilage, and it covers that surface of opposing bone. And this cartilage is avascular. How does it receive its nourishment? It receives the nourishment from synovial fluid and it circulates during that joint movement. It's a very stable connective tissue and it has very slow cell turnover. However, it's very tough, it's firm, and this consistency makes it a little bit more flexible. The cartilage cushions in the bones give it that smooth surface to facilitate that movement together. Now looking on to the muscles. Now muscles account for about 50% of the body weight of most people, and it can range 40% or lower to even higher depending on how much muscle mass your patient has gained or atrophied over time. When they contract, they produce movement. So every time the patient utilizes their muscles for contraction, you're going to get some type of movement. And the next slide is going to show you all the different types of skeletal muscle movements you're assessing. There's three types of muscles. There's the skeletal, the smooth, and we have cardiac muscle as well. And so for this chapter, we're not going to be concerned with the cardiac muscles. What we're looking for are the skeletal or the voluntary muscles that are under our conscious control. And each skeletal muscle is composed of a bundle of fibers. This might be familiar to you from anatomy. These muscle fibers or fasciculi come together to make up the muscle. Now, the skeletal muscle is attached to the bone, but it's attached to a bone by a tendon. So we have bone to muscle, the strong fibrous cord, which is the tendon, and this is going to help produce the flowing coordinated movements. How I remember the difference between a ligament and a tendon is I use this acronym, My Body's Tough, MBT, muscle M, B, bone, T, tendon. Muscles connected to bone by tendon. And hopefully that will help you to differentiate the two and not get them mixed up. Next, we're going to see the different skeletal muscle movements. And you see we have flexion. This is when you bend a limb up at the joint, so making a bicep curl or muscle. Extension is strengthening the limb at the joint and moving it outward. Abduction is moving the limb away from the midline of your body versus adduction, you're adding it to your body or moving the limb toward the midline of your body. We have pronation versus supination. How I remember that is if you want soup, you have to put your hands out. So that's supination, or where we get the terminology supine, versus pronation or prone, when you have your hands towards the floor or your palms toward the floor. Circumduction is moving the arm in a circle around the shoulder. Inversion is moving the sole of your foot towards your ankle, and then eversion is moving it away. Rotation, an example of rotation is moving your head around the central axis. Protraction is moving the body part forward and parallel to the ground, and retraction moving it inward. And an example of protraction and retraction would be your jaw at the TMJ and moving it forward and backward. And then we have depression, which is lowering a body part. So an example of depression would be when you are assessing the cranial nerve 11 and pressing it down and seeing if they have range of motion of their shoulders. The temporomandibular joint we're familiar with because we've been assessing cranial nerve 5. Well, this joint allows 3 different types of motion. We have a hinge action, which allows us to open and close our jaw. We have the gliding action, and this helps us with protrusion and retraction. And then we have the gliding for side-to-side movement, which we can do with our lower jaw as it moves side to side. Now, the TMJ permits jaw function of speaking and chewing as well. And when we have crepitus and the bones rubbing against each other, this could be a point of pain and interference of being able to speak and to chew. The TMJ, or the temporomandibular joint, is articulation of the mandible and the temporal bone. Next, we have the spine. And in the spine, we have the vertebrae, the landmarks of the spine, and the intervertebral discs. And we know that if you're looking at a lateral view, you can see 4 curves. We've talked about them before. We have that double S shape. We're looking at the cervical, the lumbar curves, which are concave, meaning they're inward or anterior. And then the thoracic and the sacrococcygeal curves are convex. This allows us to have balance and compensatory nature of the curves together with the intervertebral disc, allows our spine to absorb any type of shock, and the discs themselves are very elastic, and they constitute 1/4 of the length of the entire column in between the vertebrae. Now, from a lateral view, it would show vertebral columns. We have the 4 curves, again, that they're double shaped. And so going back and reviewing the cervical, the lumbar, thoracic, and the sacrococcygeal, and understanding which curves are which, inward or convex. The vertebrae are 33 connecting bones stacked in a straight, hopefully, vertical column. And they can feel very spinous, sharp, because you have the spinous processes, and they furrow down the middle of the back. In a human, we have 7 cervical, 12 thoracic, 5 lumbar, then 5 sacral, and then 3 or 4 coccygeal. The landmarks that we've learned, but I'll review them again, is we know that the spinous processes at C7 and T1, that's the ones that are prominent at the base of the neck. When you put your chin to your chest, you can feel those. we have at T7 and T8, this is where you're going to feel and be able to palpate the inferior angle of the scapula. And then there's that imaginary line that connects the highest point on each of the iliac crests, and that is at about L4. You can also see this imaginary line joining the symmetric dimples over the posterior superior iliac spines across the sacrum. I wanted to show you a picture here now of an actual human, where you can see with the schematic how it lines up. And so you see that C7 and T1 all the way down. So you can eyeball this too. If you're not able to feel each vertebrae, you can typically eyeball these landmarks. The next joint is at the shoulder, and this is the glenohumeral joint. And this is where the humerus and the glenoid fossa of the scapula come together, make this articulation. And it's a ball and socket joint. You might have heard of that too. And the ball and socket action allows the mobility of the arm, and it allows it to go in many different axes. So if you have a ball and socket joint, you have a lot of mobility in that joint. Here in this area, we have the rotator cuff, and that is a group, of 4 muscles and tendons that support and stabilize the shoulder. And there's some palpable landmarks that can help guide your examination. We have the scapula, the clavicle, and coming together, they form the shoulder girdle. And you can feel the bump of the scapula's acromion process at the very top of your shoulder. You can see that bump at the end. So there's an indentation here of the shoulder girdle, and then the bump, which is the acromion process. At the elbow joint, we have 3 bones that come together to make this articulation. We have the humerus, the radius, and the ulna of the forearm. This joint itself, it's a hinge joint, so it makes a hinge motion and at the radius and the ulna on one plane, and then it allows flexion and extension as well. There are also palpable landmarks here. We have the medial and lateral epicondyles, and they're at the humerus. And then you have the large ocrinian process of the ulna between them. So you can feel that as you're flexing and extending your elbow joint. The radius and the ulna articulate each other at 2 radial joints, one at the elbow and one at the wrist. And this is what allows the pronation and supination of the hand and forearm. Now, looking at the bones of the hand, we start with the wrist, and this is called the radiocarpal joint, where the radius and the radius at the thumb side and the row of the carpal bones articulate together. And it makes a condyloid action. And the condyloid action prevents movement in 2 planes at right angles, flexion and extension, and side-to-side deviation. The mid-carpal joint, the articulation here allows for some flexion, some extension, and even some rotation. The metacarpophalangeal joint and the intraphalangeal joints are on your finger, and this permits flexion and extension. And then the flexor tendons here at the wrist will allow your wrist and hands to enclose at the synovial sheath. We have the hip bone coming together with the acetabulum, which is the head of the femur. It comes together at the anterior superior iliac spine, the ischial tuberosity, and the greater trochanter of the femur. So coming together, we have the hip. And this is another ball and socket action joint, just like our shoulder. So we have that movement again across many axes. There is less range of motion, though, in the hip joint than we have in the shoulder. And this is so that we have more stability for weight bearing. Now, the hips are very stabilized, and this is because at this area we have very powerful muscles that spread over the joint They're strong, fibrous muscles that articulate in this capsule, and they're deeply inserted into that head of the femur. There's also three bursas that facilitate movement in this joint. So when you are doing your assessment, you can actually palpate these bony landmarks, and this is going to help you and guide your examination. You can actually feel the entire iliac crest from the anterior to the superior iliac spine to the posterior. You can feel the ischial tuberosity, which lies just under the gluteus maximus muscle, and it's palpable when you have your hip flexed. And the greater trochanter of the femur, just below the iliac crest and between the anterior superior iliac spine, or the ASIS, and the ischial tuberosity. Those are felt best when the person is standing in a very flat depression on an upper lateral side of the thigh. So you can have them laying on their side. Now let's look at the landmarks of the knee. The knee joint has an articulation of three bones. It's the femur, the tibia, and the patellar. And it's a very common articular cavity, known because it's the largest joint in the body. It has a hinge action that allows flexion, extension, which gives us single plane movement. It's also synovial joint. It's the largest synovial membrane in the body. And there's a sac at the superior border, right at the patella. And then there's a suprapatellar pouch that come together to allow for this synovial movement. We also have two cartilages, and they're wedged together. One is the medial and one is lateral meniscus. And there's also the cushion of the tibia and the femur here as well. Now, the two ligaments that stabilize the knee, or actually I should say the two sets of ligaments, are the cruciate and the collateral. Now the cruciate ligaments give anterior and posterior stability, and this helps control rotation. So if you ever heard of an ACL injury, this is what they're talking about. The anterior cruciate ligament is damaged. Collateral ligaments actually give medial and lateral stability, and it helps to prevent dislocation of the knee. And the landmarks that you want to be familiar with on the knee joint are the quadricep muscles that you can feel in the anterior and the lateral thigh. The muscle heads actually merge into this tendon that come together and makes that bony patella. Then it inserts down into the tibial tuberosity. You can see that on the slide here, and it's felt as that bony prominence right midline of the knee. And you might be able to feel the lateral and medial condyles of the tibia and the lateral and medial epicondyles of the femur on each side of the patella as well. And the last joint we're going to talk about is the ankle and foot. And this is called the tibio-talar joint. This is where the tibia, the fibula, and the talus come together. And again, it's another hinge joint. So it's limited to the flexion and extension. So flexion meaning dorsiflexion, and then extension meaning plantar flexion, again against one plane. Now the landmarks that you can feel, there are two bony prominences. There's the medial malleolus, and then there's the lateral malleolus. And the medial malleolus, this is where you're feeling for pulses using this landmark. These very strong, tight medial and lateral ligaments here that extend from each malleolus into the foot. And this helps with the stability laterally of your ankle. And so it could be torn if you have sudden eversion or inversion that goes outside of the plane. And this could be seen as a sprained ankle. We also have joints that are distal to the ankle, which allow additional mobility to the foot. And so we have the subtalar joint, which gives us the ability to invert or evert the foot. We also know that the foot itself has a longitudinal arch, and this helps us with weight bearing. It helps to distribute that weight between parts that touch the ground and the heads of the metatarsals and the calcaneus, which is the knee, or excuse me, the heel. Moving now quickly to developmental competence. By 3 months of age, we know that the fetus has already formed the skeleton of the cartilage. And I'm talking about 3 months in utero. And the bone is going to continue growing pretty rapidly during infancy, throughout childhood, and then in adolescence, you're going to have this growth spurt. And the longitudinal growth will continue until the epiphyses will close, and that last closure typically will end at about 20 years old. So you're going to keep growing until you're about that age. Now, though skeletal muscle, or excuse me, the skeleton itself contributes to linear growth, so how tall you're going to be, muscle and fat is significant for weight increase. All throughout life, your muscles are going to increase with use, and then as you're not using them, they're going to decrease as well. And so we know that this has to do with our mobility, our activity, and genetics, nutrition, and exercise. For pregnant women, because of this increased level of circulating hormones, so we know we have estrogen, relaxin from the corpus luteum, and the corticosteroids. This can increase mobility in the joints, but it's needed, right? Because if we're going to have a baby, we need this increased mobility in that sacroiliac area, the sacrococcygeal area, and the symphysis pubis joints in the pelvis, which contributes to very noticeable changes in maternal posture. So we talked about the lordosis, and it just changes everything about the way the woman carries her bodies, and it also will affect their joints. The most characteristic being lordosis. We also know that the shift in weight and strain could be put on the lower back, especially during late pregnancy as the fetus continues to grow and push organs and displaces organs. We know that there could be anterior flexion of the neck and slumping of the shoulder girdle and other possible changes that are going to compensate as the spine is moving into this lordosis curvature. Another thing that happens to pregnant women, or could happen to pregnant women, and it usually happens around the third trimester, is that they'll actually get carpal tunnel. And this is because there's increased pressure of the ulnar and medial nerves. And typically this will resolve after pregnancy. For our aging adults or our oldies but goodies, once you get into about 80, 90 years old, your fat will just further decrease, especially in your peripheral areas. And it's most noticeable in the forearms, and sometimes over the abdomen and hip, you can see that they get a little bit more bony. You're losing that sub-Q fat. There's an absolute loss in muscle mass that will occur. And sometimes it decreases in size and atrophies, and therefore you're going to have more weakness as well. The contours of the muscles itself start to change. And remember, though, that all of this also has to do with lifestyle. So the more active you are, you might see the changes more slowly, and the less active you are, you might see it more readily. Now we're going to move on to the subjective data or health history questions that you might want to focus on with your patients. So with the musculoskeletal system, it's either going to be the joint, the muscle, or maybe it's an issue with the bursa. And the other signs and symptoms that they're talking about, complaints, are all going to fall under one of these things. So with the joint, you're asking them if they've ever had problems with their joints, if they've ever had any pain, and then of course you would old cart the pain. You want to know what type of pain. Is it stiff, sharp, achy, dull, shooting, how severe it is, how long, when did it start. Something that's really important with joint pain is knowing what time of day it gets aggravated most, or if it gets relieved at a certain time of day. Also, what types of motion most aggravated. And then sometimes these joints can be triggered, or joint pain can be actually triggered by weather as well. And you want to know what types of medication your patients are taking to help with the joint pain. A lot of the time they're just taking ibuprofen and they're not really paying attention to how much, and that can be an issue later for their GI system. You want to know if their pain is associated with chills and fever, maybe some sore throat, and head, ears, neck type of symptoms as well, because maybe their joint pain has to do with having the flu, or maybe it's a sign that they may have COVID. You also want to differentiate that with repetitive action pain or repetitive activity. So this joint pain and stiffness would occur because of overuse. And you also want to ask your patient about swelling, heat, and redness inside the joint. You're looking for any types of signs of infection. And if there's any limitation in movement, you want to note that as well. Other things that you might ask about if they've had any tests, specifically x-rays, but maybe even CT scans or MRIs of the joint, when that was and what the results were. Now, moving on to muscles now, you might ask if they've experienced any muscle cramping, and specifically what muscle, of course. If they've had any pain with walking, any weakness or loss of strength. You want to ask where that weakness or loss of strength has been, or any signs of atrophy. How long have they noticed these signs and symptoms for? And is it limiting their ability to be coordinated or to hold up their weight and bear their weight? And you might ask them if they've noticed themselves if one muscle group does not appear symmetric to the other muscle group or the other side, right versus left. For bones, I'm asking them if they've had a history of pain, deformity. Is it new deformity, or is it history of an old deformity due to injury or trauma? I want to know if it affects their range of motion. I also want to know if they've had any injuries as a child, any fractures, sprains, strains, dislocations, any type of back pain, and then where on the spine, what part of the back the pain is felt. Do they have any nerve pain related to that? So maybe they have the shooting or radiating pain as well. Any numbness and tingling, any limping. Um, if they do have numbness and tingling of their what they may um, think is their bone or their joint, and it's limiting movement, I would also ask questions to rule out any type of neurological reason of why they're having this type of pain and rule those things out. And as we get older, we are more prone to osteoporosis. And so asking them about their history of osteoporosis within their family as well. And then, of course, for all of these things, going back to the overuse of pain medications and ibuprofen type medications, you do want to ask if they are using these medications and how much. Other questions related to health history really have to do with their ADLs, or how they're able to function, activities of daily living. And you want to know if any of their complaints are limiting their ability to do the things that all of us need to do to function every day. Take a bath. They might have issues turning on faucets or turning their shower on, toileting. Maybe they're not able to um, um, uh, create an environment where they can have good hygiene because of their limited range of motion in their fingers, their wrists, their arms, their shoulders. They might even have trouble buttoning up their shirt, using zippers or fastening themselves, pulling up their pants, maybe even putting on their shoes. You're thinking about things like grooming, activities like shaving and combing our hair, brushing our teeth. Maybe they have trouble eating because they can't prepare their meals. They can't stand for long periods of time. They can't pick up cans and open with a can opener, or even have the motion of bringing food to their mouth. Other things that you might want to ask if there's trouble with communication, thinking about having trouble writing, maybe using their phone, or even with their mouth, because their main complaint is here at the TMJ. They're having trouble talking or opening their jaw. In terms of self-care behaviors, I'm thinking about occupational hazards that can affect the use of their muscles and joints. And so I will ask them what type of occupation they have. Do they do heavy lifting or repetitive motion that's causing chronic stress on the joints? Also, I want to know about exercise routines and habits. Have they gained a lot of weight recently, lost a lot of weight recently? Do they have some type of unusual diet, or they're taking out certain types of proteins or calciums, or something in their food groups that might not be giving them the nourishment they need for their bones and their muscles to thrive. And then lastly here, I'm looking at chronic disabilities, a history of chronic disability that they have already had, or is it something where it's brand new and it's due to trauma or an accident or an injury? And I might ask about their family history of chronic disabilities, depending on what they tell me. Additionally, for infants and children, I'm trying to find out if there were any traumas at birth, if it's an infant during delivery, and sometimes that happens with the head if it's too big to go through the canal, or the shoulder gets displaced, or they're using mechanical help with the delivery, like forceps or maybe a vacuum. You want to know about the motor milestones. If the patient or the child is meeting all their developmental milestones. Sometimes it's not just musculoskeletal or gross movement, it has to do with their neurodevelopment as well. Any broken bones and any broken deformities are very important. For adolescents, I want to know about sports. I want to know what they do to prepare for a sport or sporting event. Do they use the special equipment that is required? So, if they're football players, are they using appropriate helmets and pads? If they're riding their bike, are they using their helmets? What are they doing to warm up? What do they do when they get hurt? This is very important because sometimes adolescents feel the pressure of playing a sport and not being able to speak up when they are hurt, and they'll try to play through it, which then we know from some past experience that this can make things actually even worse because they're not taking the time to recuperate their body. For aging adults, you will do a functional assessment using some type of scale, which I'm going to show you a couple of examples in just a minute. And you're going to ask some questions that help us to understand if there's a loss of function or the loss of the ability to provide self-care for themselves. Does it provide a safety risk? Then you're going to ask them specifically about weaknesses, any fall risks, or have they had a fall or stumbling. You want to know if this is increasing over time. You might want to ask about mobility aids or assistive devices that they have in their home, and if there's situations in their home that might make it harder to be mobile and safe. So going back to ADLs, here is the CATS activities of daily living. This is one example of a scale that you can do. And so if they can do it independently, you give them a 1, and if they need some dependence to perform the activity, you give them a 0. So obviously the higher the score, the more independent they are. And this scale is a little bit different where you will tally it all up. It's called the Lawton scale. Again, asking questions that have to do with using the phone, providing meals by shopping, prepping, housekeeping, laundry, etc., modes of transportation, just going through it all and tallying their level of independence. At this time, you might want to take a break and come back and join me in just a second, and we'll be talking about the objective data or the physical exam itself. When preparing for your exam, you will need to decide, are you just screening the musculoskeletal exam, or are you going to do a very complete musculoskeletal exam? And so the complete musculoskeletal exam, this is going to be appropriate for someone that has an articular disease. We know that they're having musculoskeletal symptoms and there's already a problem with their ADLs. Versus a screening musculoskeletal exam, which is a little bit more general, and it suffices for most people. And you'll see that the screening musculoskeletal exam is what we've been teaching you and what we're going to ask you to perform in our lab environment. So some equipment that you might consider using is a tape measure, if you're trying to measure lengths of joints, or excuse me, of bones. A goniometer, this is going to help you to measure joint angles if there's limitation in range of motion, and a skin marking pen as well, though most likely not necessary in our lab. So starting with inspection and moving down, we're going to inspect the size and contour of every joint. And we start here at the TMJ and we're going to move downward. We're looking at not only the size and contour, but we're going to look at the skin and the tissues over the joint. Okay, so we're looking for color, swelling, any masses, deformities, anything that's going to tell us that maybe that joint is irritated. We're also going to palpate, checking for skin temperature. We're checking the muscles themselves and the bony articulations, putting our fingers across, seeing if it elicits any pain or tenderness. On all the areas of the joint capsule, we're going to notice heat, tenderness, swelling, masses, or some type of inflammation. We're looking to see if the tenderness your patient might be feeling is localized to that specific joint or anatomic structure, or is it radiating to other areas. Then we're going to inspect their range of motion and test their muscle strength. So for range of motion, you will have them perform active voluntary range of motion while stabilizing the body proximal to that area being moved, and that way you can also feel and palpate. And then it was definitely necessary for you to familiarize yourself with each type of joint and what is normal. What type of joint is this? Is this a hinge joint? Is this a ball and socket? And how much mobility is normal? You will need to know that to be able to do an effective exam. You also will have to know what normal range of motion is and recognize limitations when your patients aren't able to move that joint the way most of us can. And you will look to see if there's any tenderness, any pain, or any crepitation when they're doing this active range of motion. And sometimes I'd like to start with very passive range of motion. Well, I will move them first just to get an idea and have an opportunity to palpate, and then I'll have them do their own active range of motion. You're also looking for crepitus. Now, crepitus sometimes can be normal, just a little crack that you can hear at the tendon or the ligament when it slips over the bone during motion, and sometimes crepitus can be very painful as well. So you want to be able to note the difference there, and if it does elicit pain with crepitation, you want to ask more questions and make sure that you are documenting appropriately. Now we're going to move to the joints themselves. So the TMJ, you're inspecting that joint area. As they open up their mouth, you're going to have them open their mouth up to the maximum ability. Then you're going to have them protrude their lower jaw side to side, stiff out that lower jaw, and then you're going to palpate the muscles of mastication around that area. So what you're going to do is when the person is seated, you're inspecting this area just anterior of the ear. You're going to place the first two tips of your fingers and ask the person to open and close their jaw. Drop those fingers into that depressed area of the joint, and it should elicit a very smooth motion right at the mandible. You might hear audible or palpable snaps or clicks, so sometimes that's okay if there's a crepitus, but what you want to make sure is that there's no pain. You're palpating that contracted temporalis and masseter muscles as they clench their teeth. You can have them do that, and you can compare the location right and left for size, firmness, and strength. And then as they move their jaw forward and more laterally towards your resistance, this test will actually test the integrity of this cranial nerve, which is cranial nerve 5. Then you're checking the cervical spine. You're checking the alignment of the head and neck. You can see here you want to do ear to shoulder, ear to the other shoulder. I have them put their chin down to their chest and then back and move it side to side and all around. And you're repeating these motions now. You can put a little bit of force upon them, like I showed you in lab, making sure that they have strength against opposing force. This is called maintaining flexion against full resistance. And this is part of your cranial nerve 11. Then at each joint here at the wrists and the hands, you have to be very meticulous and it could be very tedious, but every single joint, you are inspecting the hands and the wrists at the dorsal and the palmar sides. You're looking for contour, position, shape. You're making sure there's no swelling, no redness, no deformities, no nodules. Everything should look nice and smooth except for the knuckle wrinkles. There shouldn't be any swelling. There shouldn't be any lesions. The muscles themselves should appear pretty full. And you're going to palpate each of these joints, each of the joints itself. And you're supporting the hand with the fingers under so you can palpate with the wrists and all the way at the thumbs at the dorsum area. Making sure that they're smooth, there's no swelling, there's no bogginess, no nodules, and no tenderness. Then you're going to move on to the metacarpophalangeal joints, the MCP joint, with your thumbs, and you're just going to go distal from side to side, going through each knuckle, making sure that there is no synovial thickening, there's no tenderness, warmth, there's no nodules that you're seeing. And then you're going to test the muscles. And you can see you have your patient move their hands up and you're putting a opposing force on them. You want them to be able to take a fist and open their wrist, move their hands down at the wrist as well. Okay, so every single joint. Then you can actually ask them to flex their hands against your palm and against your own palm, and this is showing resistance of strength as well. And there's two tests that we didn't talk about in lab, but I want you to see this here. You don't have to perform it in lab, but you do need to know this for the exam. The difference between Fallon's test and Tinel's test, and they both test for carpal tunnel. So with Fallon's test, you're going to ask the patient to hold both the back of their hands backwards like this while they're flexing, and this is at a 90-degree angle, and they should be able to hold their wrist like this for 60 seconds, and it shouldn't produce any symptoms. If they have any numbness or burning, it could mean that they have carpal tunnel syndrome. Tinel's test is different. This is when you're actually percussing on the medial nerve and right at the wrist. Normally, you shouldn't have any symptoms, but if this percussion of the median nerve produces burning, tingling, along the distribution of the nerve, then this is a positive Tinel sign, and it could suggest that the patient has carpal tunnel. Then we're moving on to the elbow. You're going to inspect the size and contour in both a flex and an extended position. Again, you're looking for redness, swelling, deformities. You're going to check that olecranon bursa, making sure that there's no pain or swelling in there. You're going to palpate the elbow when it's at about a 70-degree angle, and then also when it's relaxed. And how you do this is you use your left hand to support the person's left forearm, and you're going to palpate the extensor surface of the elbow, which is the olecranon process, the medial and the lateral epicondyles of the humerus, with your right thumb and your fingers. And you can see that in the picture there. And then you're going to do the same thing with the other hand, and excuse me, other arm. Test range of motion, make sure that they have muscle strength. And so that's when you saw when I had you flex and extend in lab, I'm putting that opposing force as well. You want to make sure that they can pronate and supinate their hands, and you want to give them opportunity to do it bilaterally so that you can compare both sides. Then at the knee, you're going to inspect and palpate the joints and the muscles. Typically, you would want your patient to remain supine with their legs extended, and you're looking at the lower legs for alignment, for length, and it should be able to extend in the same axis as the thigh. You're looking at the knee, you're looking at the shape and the contour, and usually it's distinctly hollow on each side of the patella. You're checking for fullness or swelling. You're looking at the contour, and then any location of abnormal swelling around the area. Check the quadricep muscle as well on the anterior thigh, and you're looking for any type of atrophy. This could suggest that maybe they're not as mobile as they're letting on, and this can be concerning because this area, again, has a great deal to do with the stability of the overall body and most of your lower body mobility. You can also palpate when they are sitting up, and this enhances palpation with the knee that you did in the supine position as well. And so there's some things that you want to do, not just the range of motion, but you can check for the bulge sign, and you can check for ballottement of the patellar and see if there's any fluid in that knee area. The bulge sign itself, there's a YouTube videos here for McMurray's and bulge sign, and you can see if there's a fluid in this area, and sometimes this is the source of pain. You want to also check McMurray sign to see if there's any possibility of meniscal tear. So although you're not going to be performing these in lab, I do want you to be familiar with them for our lecture. At the hip, you can inspect the hips when the person's standing, but you can also inspect the hips when the person's supine. So inspect and palpate both times and both positions, and you're looking for range of motion, and you will have them raise their leg, see if they can get their knee to your chest, and then I'll take that flex knee and move it over the hip and then swing it laterally and medially, and then if they're standing, I have them swing it side to side, and this will tell me about their hip mobility. Now when they're standing, I typically will have them bend and touch their toes. I'm looking for that symmetric levels of the iliac crest over that hip joint and making sure that there's no gluteal folds, that the size of their gluteus maximus or their buttocks are the same, and that they have smooth, even gait, showing me that they have equal leg length and functional hip motion. So as you are inspecting their gait as part of the neuro exam, this again intertwines with the musculoskeletal exam too. Then, even when they're standing, you might have them do a range of motion by abducting and adducting at the hip joint. If you know your patient's stable, this might be done sitting up, and if not, you might have them laying supine and moving and adducting and abducting. And then lastly, you want to check for strength and stability too. So you will provide, that opposing force as they're moving their muscle one way. You're putting that opposing force to see if they have the strength. At the ankle and the foot, you're inspecting while they're sitting, standing, and they're walking. You're palpating those joints, starting with the metatarsophalangeal to the interphalangeal. And you're comparing both feet, looking at the contour of the joints. This should be aligned. The weight bearing should fall on the middle of the foot. And you might not see this on most people, but some people will have a flat foot and leads to higher instep. Toes should point straight forward and lie flat. You want to look at locations if there's any calluses or bursal reactions as they are allowing you to examine their foot. Any type of abnormal friction going on. You might look to see what type of shoes they're wearing as well if they need accommodations. Sometimes you can note that on their footwear. You're going to support their ankle by grasping your heel with your fingers, and you're going to palpate with your thumbs in those joint spaces, making sure that they're smooth, there's no tenderness, there's no swelling. And you're going to take each of their toe joints, now the metatarsophalangeal joints between your thumb and your dorsal fingers, and you're checking again. Range of motion, have them wiggle their toes. You're testing strength, and you're going to assess this by having them maintain dorsal flexion and plantar flexion against your resistance. So this is when I showed you push down on the gas pedal and then press up against the resistance. Then the physical exam will end with the shoulder and the spine. So at the spine, you're inspecting and comparing both shoulders posteriorly and anteriorly. You're checking size and contour of the joint, comparing them for equality of their landmarks. There's no redness, no atrophy, no deformity or swelling. You're going to check anterior as well, the joint capsule, and at the subacromial, acromial bursa. You want to check for any abnormal swelling here, but don't attempt, if you know they have a no neck trauma, they've been in a a motor vehicle accident, you're not going to do this assessment to preserve their cervical spine. If a person reports shoulder pain, you want to ask them just to point what spot hurts. On the unaffected side, you want them to point. So if it's their left shoulder, don't have them use their left hand to point at the shoulder. Okay, so you might increase that pain. Use the opposite hand or opposite arm to show you where their pain is. Now, the shoulder pain may be from a local cause or it could be referred pain. Sometimes even cardiac or gastrointestinal pain can cause shoulder pain, making sure that you're thinking about this when someone talks about their shoulder pain. And you want to look to see if this pain is from something very localized here, or can it be a symptom of radiation or just tenderness upon palpation or extensive motion. Look for any signs of spasm or atrophy of the muscle, any swelling, any heat. You're looking for any redness, and you're palpating both front and back of the person, making sure that you're checking bilaterally. So some of the motions that you might want to test for range of motion is arms forward and back, up and down, side to side. You're doing circumduction. And then again, and you might actually have them put their hands behind their head. But again, you're doing all these things, active range of motion, and then you can add some strength to resistance as well. And this, reminding you that this is cranial nerve 11, and you can test that with strength to resistance as well. And then finally, the spine, you're going to inspect when the person is standing. And if you're in a clinic, you're going to make sure they're draped and the gown is open in the back so you can see their spine. If they are in a hospital setting, you might need to assess their spine only when they're sitting in the hospital bed, or maybe during linen changes when you have them on their side, depending on their mobility and the situation of your patient. But you want to place yourself far enough back so that you can see the entire back, inspecting to see if it's straight, making an imaginary line from head, going down to the gluteal cleft, making sure that each of the spinal processes follow. So what are you looking for? You're looking for scoliosis, lordosis, kyphosis. You're looking to see that there is no redness, there's no swelling, signs of infection, or skin deformities. You're looking to make sure that the position of the shoulders and the scapula, the iliac crest, and gluteal folds are equal bilateral in the positions that you expect them to be. Go back and look again at the landmark charts. You're going to make sure that their knees and feet are aligned together with the trunk and that they're pointing forward and they're straight. You might have them move side to side to see what type of rotation they have at the hip. You can also, if they are laying back in a supine position, you can have them do the straight leg raise, which helps us to see if there is any lower back pain. Sometimes with the straight leg raise, you can elicit some pain. And when you do this, you want to keep their knees extended normally. You're going to measure. If there's any leg length discrepancy, then you would measure. Otherwise, we're not measuring joints, arms, and legs. But when you measure, if you have to do this, we all measure at the same place to make sure that we are in uniform agreement. Check from the anterior iliac spine, or the as is, and you're going to the medial malleolus. And so this will help everybody to understand what the length is and make sure that we're not increasing or decreasing because we're measuring from different pinpoints or landmarks. Normally these measurements are equal, or they're only within 1 centimeter apart from each other. So in review, you're going to inspect and palpate every joint area. You're looking for size, contour, shape of the joint, skin color, checking for the characteristics, making sure there's no signs of infection, heat, discomfort. You're palpating over the skin, the muscles, the articulations, and joint capsules. So any swelling. And then you're going to check for tenderness, and then move on to range of motion. Active and passive, especially if they aren't able to do the active, you might try to do the passive range of motion. And then you're going to measure with a goniometer if there is an abnormality. And the way that that works is kind of like a protractor, where it opens up to the joint angle, or how, like if we're talking about my elbow here, what angle I can open up my joint, then you'll use the goniometer to measure that, and it gives you a number. And then at each major muscle area or joint area, you're also going to do muscle testing. So this is that strength to resistance, and you want your muscle strength to be 5 of 5. Let's look at the sample charting and you'll be done with your lecture for today. Here you have, in subjective, states no joint pain, stiffness, swelling, or limitation. There's no muscle pain or weakness. There's not a history of bone trauma or deformity. Your patient is able to manage all their usual daily activities of living with no physical limitations. Their occupation involves no musculoskeletal risk factors. Exercise pattern is a brisk walk 1 mile a week, 5 times a week. I said that wrong again. 1 mile 5 times a week. And then for objective, this is your actual assessment. Their joints and muscles are symmetric. There's no swelling, masses, deformity, normal spinal curvature, no tenderness or palpation of joints, no heat, swelling, or masses. They have full range of motion. Their movement is smooth and even with no crepitus, no tenderness, and their muscle strength, able to maintain flexion against resistance at all joints without tenderness. Now, if you are working with your partner this week, make sure that your subjective is catered to them. And you see here in objective, you don't have to list all the joints if they're all within normal limits. However, if you do notice that there are some discrepancies or abnormalities, then you're going to pull out that joint and talk about that specifically. For instance, if there's something wrong with the TMJ, then I'm going to talk about the TMJ specifically. And then I might say, generalized everything else to the other joints. Or if there's 2 joint areas, then you're going to call those 2 joint areas first. So typically I'll do the abnormals on the top and then move on to the normals. If you have any questions, let me know. Have a great rest of the week.